오전에는 2개의 영어 세션들이 준비되어 있고 첫 번째 세션은 Next Generation Therapeutic Avenues Targeting ASCVD라는 제목으로 진행이 될 예정이며 서울 아산병원의 이철환 선생님과 서울성모병원의 장기욱 교수님께서 좌장을 맡아주실 예정이십니다. 장기욱 선생님께서 오프닝과 함께 시작을 부탁드리겠습니다.
네, 저희가 매년 12월 중순에 한 해를 마감하고 이제 새로운 해를 준비하는 이런 모임을 벌써 8년째 지속하고 있습니다. 참여해주신 모든 교수님들께 감사드리고 오늘 모임이 좀 잘 성공적으로 이루어져서 좋은 임프레션을 가지고 마감되었으면 좋겠습니다. 그럼 첫 번째 세션 시작하도록 하겠습니다. 혹시 리리커 선생님 여기 지금 나올 수 있나요? Hello, Dr. Lidker. So I'm Gyuk Jang from Korea. So we cannot hear you.
Can you hear me now?
Yeah, the voice is weak. So can you please, speak up?
Is that better?
Okay. So thank you for joining our symposium late Friday morning. So we are all low, or well low you. So no need for introduction. And however, I'm certainly saying that you are the leader in establishing anti-inflammatory therapy in atherosclerotic cardiovascular disease, worldwide. So we all hope your speech can give us hope for the next generation therapeutics in this field. So please start your lecture.
Well, good morning. First, can you hear me well?
Yeah, we can hear you. Yeah.
Thank you so much. It's a great honor for me to join you. And actually, I hope to come to Korea next year. I'm scheduled to visit in September for the ICOLA and Korean Society Lipid meeting. I look forward to meeting many of you in person. But I'm honored today to be able to participate in your Winter COACT Symposium and to open this session on next generation therapeutic avenues targeting atherosclerotic cardiovascular disease. And as Professor Chang said, yes, I'm particularly interested in inflammation and atherosclerosis, and I will talk about targeting residual inflammatory risk, the next frontier for atherosclerosis treatment and prevention. I have a variety of conflicts related to this. My research group has been interested in almost 30 years now in a fundamental question, which is, can inflammation inhibition reduce cardiovascular event rates and in some settings improve kidney function? That's relevant because I know that many of you in Korea are working with us on our ZEUS clinical trial of a novel interleukin-6 inhibitor, which I'll come back to. Our patients with atherosclerosis often suffer from kidney disease. And on the right-hand side of the slide, I show you an outline of a very important pathway from the NLRP3 inflammasome, where interleukin 18 and interleukin 1 beta are activated. These occur in cells throughout our bodies, upregulate the central signaling cytokine interleukin 6. Interleukin 6 has a variety of direct effects on the vascular endothelium, as does IL-1 and IL-18, but it also puts out our simple clinical biomarker, C-reactive protein that you know as high sensitivity CRP. And in this talk, I'm going to try to give you an outline of how we learned this and where the field is going today. What's most exciting is that here in the United States, for the very first time, the United States Food and Drug Administration has approved the very first anti-inflammatory therapy for atherosclerosis. That drug is low-dose colchicine given at 0.5 milligrams once a day. I show the actual US FDA indication for you here because it's quite striking. It says colchicine, low-dose colchicine, is indicated to reduce the risk of myocardial infarction, stroke, coronary revascularization, and cardiovascular death in adult patients with established atherosclerosis, so secondary prevention, or with multiple risk factors for cardiovascular disease, high-risk primary prevention. That's the exact same label in the United States that we have for statin therapy. So this is a very exciting issue for us to now have FDA approval of the first anti-inflammatory drug specifically for atherosclerosis. So I want to describe how we got there. In 2016, I wrote an editorial for the European Heart Journal where we coined a new term that you know as residual inflammatory risk. We were trying to describe to our clinical colleagues who understood residual cholesterol risk that there's another group of patients who, once we put them on a statin, their LDL cholesterol is well controlled, but the high sensitivity CRP, the biomarker of inflammation, remains elevated. In 2016, however, we did not have evidence that lower was better. But in 2023, as we enter 2024, we have very clear evidence that lower is better both for cholesterol reduction and for anti-inflammatory therapy. To emphasize how important measurement of high sensitivity CRP is in clinical practice, I show you data that we presented at the American College of Cardiology meeting earlier this year and published in The Lancet. This is data from 31,245 contemporary statin-treated patients asking the question, what is the most powerful predictor of future cardiovascular events? The data on this slide is cardiovascular death. In 3 major clinical trials, the Prominent trial, the Reducer trial, the Strength trial, the black bars are the predictive value for high sensitivity C-reactive protein. The white bars are the predictive value for LDL cholesterol. And as you can see on the right-hand side of the slide, hsCRP is a very powerful predictor of cardiovascular death, more so than LDL cholesterol. And this is a very important issue clinically because we know we can lower LDL and lower risk. But have we begun to address the inflammation part of the story? Well, I think we can. And I show you here a slide showing the proven anticipated benefits of different LDL lowering drugs, assuming you already have your patient on a statin. For ezetimibe, we have about a 6% relative risk reduction. For the PCSK9 inhibitors, 16% risk reductions. On the far right-hand side, you see our CANTOS trial with interleukin-1 inhibition, and then the 2 colchicine trials I'll talk about. These are larger risk reductions than we get for adjunctive lipid lowering. And that's the challenge for all of us today. Has the time come to add inflammation inhibition on top of lipid-lowering therapy? But several of my colleagues, when we presented those data at the American College of Cardiology, said, well, those patients are all on a statin. What about patients who do not take a statin? So at the American Heart Association meeting just a few weeks ago in Philadelphia, we presented the data on the bottom half of this slide. The top half of the slide is the data I just showed you. Increasing quartiles of high sensitivity CRP are a very powerful predictor of future risk among statin-treated patients, whereas LDL cholesterol was not. The bottom half of the slide is the exact same story in contemporary aggressively treated patients who are statin intolerant. This data comes from the CLEAR Outcomes trial. So again, you see how important it is to know the inflammatory profile of your patient and to take action on that basis. This has been a long story for my research group that goes back to the mid-1990s. We began to publish a series of papers in the New England Journal of Medicine describing the fact that different inflammatory biomarkers predicted risk with at least as much predictive utility as did cholesterol itself. The question became, can we modify that risk? Well, most of you are aware of the results from the Jupiter trial, which we ran from 2000 to 2008. In which we showed that patients in primary prevention who had elevated levels of CRP, who would not receive a statin under any guideline at the time, got very large reductions in risk. In fact, these reductions in risk are unprecedented. A 44% reduction in the combined endpoint, a 63% reduction in myocardial infarction, stroke revascularization cut in half, and a 20% reduction in all-cause mortality. On the right-hand side of the slide, I show you that even patients who had an elevation of hsCRP and no other risk factor benefited. So these data were very important, teaching us that statin therapy, which we had previously shown was both lipid-lowering and anti-inflammatory, could be maximized if we gave it to patients even if they didn't have a high LDL, but simply had a high CRP level. But the challenge for us was that Jupiter was a clinical trial using a statin, a powerful lipid-lowering drug that also had anti-inflammatory effects. In order to directly test the inflammation hypothesis of atherothrombosis, it was therefore necessary to think through a clinical trial that would not have a change in cholesterol, but that only would target inflammation. This clinical trial you know as CANTOS, the canakinumab anti-inflammatory thrombosis outcome study, which began in 2011 and was completed in 2017. Unlike Jupiter, which was primary prevention, this clinical trial is now secondary prevention. 10,000 patients who are post-myocardial infarction with stable coronary disease, all of whom have what we call residual inflammatory risk. They all had elevated levels of high sensitivity CRP. And they were given one of 3 doses of a very novel human monoclonal antibody that targets interleukin-1 beta, the drug canakinumab. In the lower left-hand side of this slide, you see that we got dose-dependent reductions by blocking IL-1, dose-dependent reductions in C-reactive protein and interleukin-6, but no change in LDL cholesterol, no change in HDL cholesterol, no change in triglycerides, and data not shown here, no change in hemoglobin A1C or blood pressure. And yet, as you see in the lower right-hand side, a 15 to 17% reduction in major adverse cardiovascular events, simply by targeting inflammation without changing ApoB or LDL cholesterol at all. And as you know well, the cardiologists know well, this is the same risk reduction that we saw the same year by giving a PCSK9 inhibitor on top of statin therapy, a drug that lowers LDL but does not lower inflammation. So CANTOS provides us proof of principle that we can indeed target inflammation directly on top of statin therapy to lower cardiovascular event rates. Now, canakinumab has been repurposed into oncology because we also showed major reductions in lung cancer, a major issue I know for you in Korea. But let's go back to the cartoon of this NLRP3 inflammasome. To move past number 1, interleukin-1 inhibition, look for a few minutes at number 2, low-dose colchicine, which was the basis of the FDA approval. And then I want to speak for a few minutes about where we're going with interleukin-6 inhibition with a novel drug called ziltivekimab. Colchicine is a drug that has been with us for a long time. It's been a pharmaceutical drug for more than 70 or 80 years. It is a drug that has many different anti-inflammatory properties, including platelet inhibition. It's an anti-neutrophil drug, and it does have properties that alter the way certain proteins aggregate and polymerize. In general internal medicine, many of you have used colchicine to treat acute gout or acute pericarditis, but you've done it by giving high doses of colchicine for very short periods of time. We're now talking about low doses of colchicine, only 0.5 milligrams daily, given on a chronic basis. There are 2 fundamental clinical trials you're aware of that provide the hard evidence that was used by the US FDA to say we have to start talking about anti-inflammatory therapy for atherosclerosis. The first of these trials is the low-dose colchicine 2 or LODOCO 2 trial for patients with stable atherosclerosis were randomized to colchicine or placebo on top of statin therapy, and they lowered the primary endpoint of heart attack, stroke, and cardiovascular death by a very large 31%. That's almost twice the reduction one gets by giving a PCSK9 inhibitor on top of statin therapy. And it's very important to recognize that the patients did very well in the trial, adverse effects were infrequent, and compliance was very, very good in this trial. We also have a second randomized double-blind placebo-controlled trial known as COLCOT. This trial was done in Europe and North America in patients who had a recent myocardial infarction, about 15 days stable post-MI. And again, 99% were already taking statin therapy. Again, there was excellent compliance, a slight increased risk of pneumonia, but here a 23% reduction in major adverse cardiovascular events. I want to emphasize to you that colchicine is not a drug for all patients. While this anti-inflammatory drug is the first approved drug in the United States, and it's in the European guidelines and the American guidelines, as I'll talk about in a minute. This is not a drug that can be given to patients with chronic kidney disease or patients with hepatic dysfunction because it is metabolized both by the kidneys and by the liver. We also want to emphasize that if you're using this drug, you probably should stop on a short-term basis certain drugs that are CYP3A4 inhibitors or P-glycoprotein inhibitors. Here in the United States, this typically would include occasional use of short-term clarithromycin, fluconazole, or ketoconazole, and as the pandemic slowly continues, perhaps the use of ritonavir. If a patient is taking one of those drugs, it's probably prudent just to stop the colchicine for that week and then restart the drug at a later date. I'm very excited as an inflammation biologist to say that in 2021, low-dose colchicine made the European guidelines, and just earlier this year, after the FDA took action, low-dose colchicine made the United States guidelines. It's also in the Canadian guidelines, and I'm certain that will enter your guidelines relatively soon. I want to talk, however, about some biology. In our CANTOS trial, which remember was an interleukin-1 inhibitor, we noticed that the biggest effect for our patients was when they had a most robust anti-inflammatory response. This is very similar to LDL lowering. When the patients get a large LDL reduction, they get better response. A large blood pressure reduction, a better response. As you see here, the patients who had the largest CRP reduction on the left, or more importantly, the largest IL-6 reduction on the right, actually got very large reduction in event rates. This is telling us that if we directly target interleukin-6, we may be able to even get greater reductions in risk than we got in the main trial. My research group has been involved in thinking about interleukin-6 for over 25 years. The very first manuscript published looking at IL-6 and risk of cardiovascular disease came from our research group in the year 2000 on the left. This has been replicated on the right-hand side many, many times over the last 30 years. We know very clearly IL-6 predicts risk. We also know from work done by my colleague Dan Chasman that in GWAS studies that IL-6 receptor is a very important driver of atherosclerosis and IL-6. We know this from PheWAS studies, and we know this from Mendelian randomization studies. So all different kinds of evidence are pointing to the fact that if we can inhibit IL-6 directly, we might get larger reductions in risk than we got by directly inhibiting IL-1, indirectly inhibiting interleukin-1. So to move this field forward, we began working with a company in just near my office here in Boston, in a suburb called Waltham, Massachusetts. The company was called Corvidia. They were developing a novel interleukin-6 monoclonal antibody that is an IL-6 ligand inhibitor. And as you see here in a phase 2 study we published in The Lancet now a year and a half ago, we were able to get much larger reductions in CRP. In CANTOS and in COLCOT and in LODOCO-2, CRP levels are coming down 35 to 40%. With this direct IL-6 inhibitor, we're getting 85 to 90% reductions in hs-CRP. And as you see in the waterfall plots, almost every patient who is giving active therapy has a very large reduction. So we hypothesized that perhaps this might be a better way to get even larger anti-inflammatory therapy. And the safety of IL-6 inhibitors has been with us for a long time. So I'm very pleased to let you know that I have the honor of being the co-chair of 2 clinical trials. They're ongoing now. I believe they're both enrolling also in Korea. I know the ZEUS trial is. ZEUS is the ziltivekimab cardiovascular outcome study. It's specifically focusing on patients with chronic kidney disease. These are patients who cannot take colchicine. They have elevated high sensitivity CRP, in other words, residual inflammatory risk, and they all have evidence of prior atherosclerotic disease and stage 3 or stage 4 chronic kidney disease. The primary trial outcome is major atherosclerotic events. The secondary trial outcome with my colleague Vlado Perkovic, who is a nephrologist, is progression of kidney disease. And I'm very proud to say that with your assistance on a global basis, this trial is now 80% enrolled. So we should have a result of this trial within about 2 years. At the same time, the sponsor of that trial, Novo Nordisk, who now has ziltivekimab, is performing a second randomized trial in the setting of heart failure with preserved ejection fraction. This trial is called Hermes, and it takes patients who again have residual inflammatory risk, with hsCRP greater than 2 milligrams per liter, with New York Heart Association evidence of heart failure and preserved ejection fraction, to see whether or not anti-inflammatory therapy can add to our armamentarium for the treatment of heart failure. There's also a third trial, which will begin sometime next year, which is a trial of IL-6 inhibition in acute coronary ischemia. Let me bring this talk to an end by talking about the clinical implications of this disease. What you see here on the 45-degree line is the canonical evidence that LDL reduction on the x-axis tracks with relative risk reduction on the y-axis. This has been known for 30 years, and it benefits from all the statin trials. But on the far left in the red diamonds, you see evidence from the CANTOS, COLCOT, and LIDOCO 2 trials that we can get substantial risk reduction without changing LDL cholesterol at all. And that's really what's changing for us today. So let me ask a few questions. The first is, who would you give anti-inflammatory therapy to today? I think it would be patients who have chronic atherosclerosis and an elevated CRP who have residual inflammatory risk. It's also very important to point out that inflammation inhibition is not a substitute for cholesterol lowering. Inflammation inhibition and lipid lowering are completely synergistic effects. They can be very aggressive with both of these directions. But what you see on this slide is a concept of living without inflammation. On the left, you see that diet, exercise, smoking cessation, statins, bempedoic acid, IL-1 inhibition, colchicine, SGLT2s, and GLP-1s all lower CRP and all lower vascular events. That's what we're talking about, and I want to thank you for your attention today and look forward to the rest of the symposium.
Thank you, Dr. Lidker, for giving us excellent lecture in future perspective. And discussions will be done after the second speaker's lecture, so please stay online. So next speaker will be introduced by Dr. Chorani.
Okay, thank you very much. The next topic is pathogenetic new mechanism of PCSK9 behind the destruction of LDL receptor, development of biotherapeutic to reduce the residual CVD burden by treating both inflammation and hypercholesterolemia. This topic by Dr. Hyo-Soo Kim from Seoul National University Hospital. Please.
Thank you for a kind introduction. It is very, we heard a very important introductory lecture from Dr. Lidker. He mentioned residual cholesterol risk as well as residual inflammatory risk. I propose the PCSK9 has two different mechanisms to induce the atherosclerosis. Obese inflamed fat is associated with cardiometabolic disease such as obesity and cardiovascular disease and diabetes as well as cancer. What happens in this abdominal obese fat is shown here. There are two fundamental physiology undergoing during the transition from lean to fat, abdominal fat. The first one is hypertrophy of adipocyte. So the second is infiltration of macrophages. These two happening induces secretion of many cytokines mentioned before, causing atherosclerosis and insulin resistance on muscle and liver. As you know, adipose tissue is not only energy reservoir organ, but as well as endocrine organ secreting large amount of cytokines, including resistin. That is my topic since 15 years ago. We first report resistin is causal factor of atherosclerosis. Resist, known as adipokine, is a key player to modulate monocytes, leading to progression of atherosclerosis. Here's the mechanism. There are four key players of atherosclerosis: mono, macrophage, and endothelial cell, and smooth muscle cells. When they were exposed to resistin, the change happened in all these four key players: induction of VCAM1 and integrins. The result is shown here: enhanced adhesion, invasion, retention, and survival. leading to progression of atherosclerosis. When I published this paper, I tried to block the resistin signal, but at that time, there's no known receptor for resistin. Thus, I tried to clone the receptor for human resistin. At the 3 years endeavor, we finally cloned the human resistin receptor, that is adenylyl cyclase associated protein 1, CAB1. RISC-CAB axis mediates inflammatory actions of human monocytes. In other words, resistin can bind CAB1, leading to induction of cycle AMP, pKa, NF-kappa B, and many cytokines in monomacrophages in human. The signal pathway is shown here: RISC, CAB, adenylyl cyclase, cycle AMP, pKa, and NF-kappa B, and many cytokines, including interleukin 6. So for the last 10 minutes, our lab focused on the big map, how RISC-CAB axis induces many disease conditions. First, in the obese abdominal fat, we have many infiltrating macrophages that express high level of resistin. Interesting findings: CAB is ubiquitously expressed in all human body, liver, artery, intestine, muscle, even cancer cells. Thus, interaction of resistin from monocytes and CAB in many parenchymal cells lead to the disease. We generate TALEN-mediated transgenic CAB knockout mice. Homo knockout mice were lethal at the embryo day 15. Thus, we were able to analyze the phenotype of hetero knockout mice. The first phenotype is reduction of fat inflammation under high-fat diet. Here is wild type animal, chow diet, high-fat diet. There's huge infiltration of brown macrophages. In other words, it turns as inflamed fat, remarkably reduced by CAB hetero knockdown. Pro-inflammatory gene expression in this fat tissue is also decreased by CAB hetero knockdown. Thus, we now summarize the paper that RISC-CAB axis is a very important mechanism to explain the metabolic syndrome. The second phenotype is reduction of hepatic steatosis under high-fat diet in hetero knockdown mouse. Here's wild type, fatty liver, like foie gras, significantly reduced in CAB hetero knockdown mice. Lipogenic gene, gluconeogenesis genes are turned down in hetero knockdown mice. We also summarized the paper to decipher RISC-CAB axis is very important pathophysiology to induce NASH, hepatic steatosis, and liver cirrhosis. The third phenotype is also very interesting: reduction of LDL-C by 15% in hetero knockdown mice. There are two key players to control LDL-C, receptor and PC9. Thus, we checked hepatic expression of receptor and PC9 in these hetero knockdown mice. Here's wild type mouse under chow diet and high-fat diet, receptor, CAB, PC9. Hetero knockdown mice, CAB is physiologically knocked down by about 30 or 50%. PC9 does not change, but receptor are accumulated. It's very interesting finding. I guess there may be some defect in the interaction between PC9 and receptor, leading to accumulation of receptor and the decrease of LDL-C in blood. Thus, we started this big project since 5 years ago, and we confirmed CAB is binding partner of PC9 and is required for the degradation of receptor by PC9. Here is a hepatocyte surface is enriched with the receptor that uptake circulating LDL-C from blood and cholesterol is used to synthesis of bile acid, receptors are recycled. In the absence of PC9, there are a lot of receptors on the surface, thus decrease of LDL-C in blood. But PC9 is also synthesized in the same way like LDL receptor, the same transcription regulator of SRABP2. When it binds to receptor cannot be recycled and degraded. Thus, receptor number on the hepatocyte are few, leading to increase of LDL-C in blood. Thus, they develop PC9 inhibitors, monoclonal antibody, to block the binding between PC9 and receptor, leading to receptor recycling and LDL-C decrease in blood. Here's binding site of receptor and PC9. EGF precursor homology domain of receptor bind to catalytic domain of PC9. There are 3 domains in PC9. But since about 5 years ago, at that time, nobody knows the mechanism of endocytosis and the lysosomal degradation of receptor after binding with PC9. We found a very interesting phenotype of cap heteronoctown mice, accumulation of receptor without any change of PC9. Thus, I guess there may be some defect in interaction of the PC9 and receptor. We found a very interesting paper. Here is the PC9 structure. Cysteine-rich domain looks like resistin. That is the starting point of our project. We already published structure of resistin trimer cap binding complex shown here under the collaboration with Dr. Sang-Ak Lee on the panel. And we found the paper resistin is very similar to PC9. C-terminal structure of resistin is very similar to cysteine-rich domain of PC9 on profile, on en face. We proposed this protein docking model, thus we expect such kind of protein docking model between PC9 and CAP. We established 3D modeling of PC9 CAP docking simulation like this, and we confirm that PC9 directly binds to CAP through cysteine-rich and SH3 domain, like this. At the receptor bind to catalytic domain of PC9, the exposed free cysteine-rich domain bind CAP through G3 domain. Such evidence is proved by 4 different methods. First, immunoprecipitation. Second, far western blot. Third, by molecular fluorescence complementation assay. 4, surface plasmon resonance assay. And furthermore, we try to map the binding motif using a series of deletion mutant of CAP. G3 domain of CAP is the motif for binding with PC9. Conversely, using a deletion mutant PC9, we confirmed CLD of PC9 is indeed the binding partner of CAP. Thus, this is the answer of our experiment. Such a notion is well realized in human real genetics. We confirmed the loss of function mutants of PC9 such as 668, 670 could not bind with CAP1. This mutation is reported in human. There are several mutations of PC9 gene in human, such as like this: bad mutation, gain of function; good mutation, loss of function, encompassing exon 1, 2, 3, 8, and 9, 12. This is prodomain, catalytic domain, and cysteine-rich domain. This is very important motive to bind CAB. Thus, we focus on 8 gene mutations, 2 bad mutations, 6 good mutations. And we prepared from a laborious laboratory work, we prepared all 8 mutant proteins of PC9, which is reported in human. Among 8 mutants, these 2 mutants showed defective interaction with CAB1. Here's the evidence. Bad mutants and good 6 mutants. Bad mutants degrade receptor. Gain of function mutants. Good mutants, loss of function mutants, enriched receptor. Among them, black is nonsense mutation, no PC9, really a longevity phenotype. And there are green, 4 green and good mutants. Among them, these 2 mutants on cysteine-rich domain cannot bind with CAB. Thus, our notion is well revealed, corroborated in real human gene. Here is these 2 mutants cannot bind with CAB. That's the reason why there is a loss of function and decrease LDL-C in blood. What's the mechanism for internalization of receptor PC9 CAB complex through caveoli or clathrin? There are 2 main endocytosis mechanisms, clathrin and caveoli dependent endocytosis. When we applied caveolin 1 siRNA, PC9-induced receptor degradation was disturbed. Caveolin is very important. When we block clathrin, there is no change of receptor degradation. Clathrin is not important. Here is immunofluorescence staining. In control conditions, receptors are degraded with lysomal activation. Such if happening does not change even we block clathrin. Clathrin is not important. When we block CAB or caveolin, receptors are not degraded even under treatment of PC9. Here's another evidence. In control conditions, PC9 degrade receptor, which is not affected by clathrin siRNA, but receptors are not degraded with CAB or caveolin 1 siRNA. Thus, caveolin is very important protein to degrade receptor by PC9. Here is the actual quadruple complex domain. Eject-precursor homologous domain of receptor bind to the catalytic domain of PC9. CLD bind C3. AC bind domain contact with caveolin. This quadruple complex internalized through caveosome, leading to lysomal degradation. In this process, CAB is required for PC9-mediated receptor degradation, leading to increase of LDL-C. If CAB is not there, even a lot of PC9 cannot degrade the receptor. PC9 is non-functional without CAB. Here's a PC9 treatment induced receptor degradation, which is blocked by CAB knockdown. Here, when we applied wild CAB, PC9 degrade receptor, but AC domain deletion mutant, Schüssel binding domain mutant cannot degrade receptor. These 2 domains are important, suggesting this model. Lysomal degradation is important. When we apply the blocker of lysomal degradation, receptors are not degraded. Proteasome inhibitor, autophagosome inhibitor does not have any impact on the degradation of receptor by PC9. Here's another evidence. Here, control conditions, receptor degraded. CAB knockdown, receptor maintained. Early endosome is not changed. In this case, degraded. In this case, recycled. Here, lysosome is activated, degraded. Lysosome is not activated, so recycle, enriched with a receptor on the surface of hepatocyte in the presence of cap siRNA. Thus, this is summary. In the absence of PC9, receptor recycled. But in the presence of PC9, it may be recycled or it may be degraded. The decision maker is CAP. If CAP is there, it undergoes cardiosome internalization degraded. Without CAP, even in the presence of PC9, receptor is not degraded. The other important thing is when LDL cholesterol level is decreased, there is the inflammatory risk. PC9 has also a player to induce the inflammation independent of receptor degradation. There are several suggestions the pro-inflammatory action of PC9 based on experimental and clinical evidences. Gain of function PC9 mutation increase such kind of cytokines. Until now, there are many PC9 resources, not only from hepatocyte, but also from monomacrophages, endothelial cells, and smooth muscle cells. These PC9 in plaque may induce expression of scavenger receptor on the surface of monomacrophages, leading to formation of foam cell. Thus, PC9 has some pathological lore to progress of atherosclerosis. Until 5 years ago, there are some suggestions, the mechanism of PC9 to activate macrophages. PC9 can increase toll-like receptor 4, leading to NF-kappa B activation, or PC9 upregulated LOX expression, enhancing the uptake of ox-LDL, leading to NF-kappa B activation. But it is unclear. For the recent 3 years, we fully deciphered how PC9 induces inflammation independently of LDL receptor. We prepared macrophages from LDL knockout mice, LDL receptor knockout. When we treat PC9, monocytes can be activated like wild-type animal. Does PC9 induce NF-kappa B, but LDL receptor is not necessary. We also introduce AAV PC9 gene to LDL receptor knockout mice. Here, we can induce atherosclerosis independently of LDL receptor. When we harvest this carotid artery and check the cytokines, huge amount of interleukin-1, 6, TNF-alpha induced by PC9, even in the absence of LDL receptor. For the last 3 years, we did an extensive experiment and established such kind of whole map, how PC9 induce inflammation independently of LDL receptor. PC9 can bind CAP, which may influence the binding of PC9 to TOR4. This is main interaction. This is a mild interaction. The downstream signal is adenocyclase, cyclic AMP, PKA, PI3 kinase, AKT, and kappa B. PI3 kinase can turn on the adhesion molecules, and if kappa B turning on many cytokines. AKT can induce translocation of SIDPP2 to nucleus, leading to translation of PC9. This is very important self-augmentation pathway. PC9 induces PC9, as well as upregulation of TOR4 receptor and LOX1. The first, PC9 colocalized with carbon on macrophagy. PC9 treatment induced change of CAB localization to the membrane. Direct evidence, direct interaction between PC9 and CAB on the surface of macrophage. Direct interaction between PC9 cap with blitz experiment on the surface of macrophagy monocytes. Direct interaction of PC9 cap in dual link experiment is shown here. Red dots suggest the colocalization of PC9 and cap, which is not affected by TOL4 blocker, LOX1 blocker. But conversely, interaction with PC9 TOL4 receptor is dependent on CAB1. PC9 TOL4 interact, but which is significantly retarded in the absence of CAP. Thus, this is main binding partner. This binding, presence of this can facilitate the binding between PC9 and TOL4. This interaction is negligible. Then PC9 turns on NF-kappa B like this, and macrophage as well as EC. Then downstream pro-inflammatory genes, IL-6, are turned on by PC9 on macrophages. These molecules on macrophage and EC, VCAM1, ICAM1 on EC, integrating alpha-4, beta-1 on macrophages, thus enhancing interaction between two cell types by PC9. Such kind of NF-kappa B cytokine activation is all dependent on CAP. When we knock down CAP, such kind of induction obliterated. But when we knock down TOL4, it's very weak effect. Thus, main mechanism is PC9 CAP axis to induce NF-kappa B or many cytokines. Furthermore, PC9 induced scavenger receptor LOX1, scavenger receptor 1, CD36 on TOL4 macrophage, all dependent on CAP. Such a scavenger receptor is activated by PC9, blocked by CAP. Uptake of OX-LDL is induced by PC9, which is also dependent on CAP. OX-LDL is uptaken by PC9 stimulated macrophages, but which is blocked by CAP, like this. Potent positive feedback loop is found. PC9 induced PC9 secretion from macrophages. Here, many bad materials induce PC9 secretion from monocytes, but PC9 is the strongest stimulant of PC9 secretion from monocytes. But this pathway is also dependent on CAP. SREBP is turned on by PC9, leading to PC9 synthesis, which is blocked by CAP. In vivo relevance, yes, PC9 or low shear stress-induced vascular inflammation or atherosclerosis is all dependent on CAP. Here's one evidence. Wild-type animal, PC9 injection induced atherosclerosis, which is obliterated in the CAP hetero knockout mice. Another evidence, low shear stress itself induces atherosclerosis like this. But in CAP hetero knockout mice, even low shear stress does not induce plaque because there's no infiltration macrophages. Risk CAP axis is very important. PIS-CAP axis is very important to induce macrophage activation. But macrophage is not activated. Even in the presence of low shear stress, no plaque, no cytokines. Thus, CAB is really pivotal receptor to induce, to mediate the bad actions of PC9. Thus, once again, CAB is pivotal molecule in inflammation and metabolic syndrome. It plays a role, a cholesterol risk. It also plays a role, residual inflammatory risk. But avalokumab does not have any impact on anti-inflammatory action because they block the receptor, a binding between either receptor and PC9. Even in the presence of avalokumab, there is still interaction between PC9 and CAP, leading to inflammation. Thus, to capture both cholesterol risk and inflammatory risk, we have to develop blocker against PC9 cap binding. In our experiment, FCCAP1 is very powerful to block cholesterol synthesis, to induce lowering LDL-C, but also to block inflammation. Thus, such kind of blocker may really realize the control of cholesterol risk as well as inflammatory risk. Thank you very much for your attention.
Thank you very much for your excellent lectures. And now let's move on to panel discussion. Today we have 5 distinguished panel, Man-Won Park, Dr. Man-Won Park, Sang-Hang Lee, Eun-Ho Choi, Yoon-Suk Choi, Eun-Chu, Yoon-Suk Choi, and Sun-Jun Hong. Now we will have an open
Can I start first? Hi, Paul. I'm Sun-Jun from ICOLA. We have met a few months ago in Austria, Graz, and looking forward to meeting you in September next year. And thank you for your educational talk. And you have mentioned in your talk that COLCA trial and LODOCO 2 trial, they have, by using low-dose colchicine, have reduced major adverse cardiovascular event. And on top of statin, right? And were there any adverse event associated with low-dose colchicine from those trials?
Sure. So it is very nice to see you. I did enjoy meeting you in Graz, and I very much look forward to coming to Seoul next September for the ICOLA meeting. And let me also begin by congratulating Professor Kim on his elegant talk and the highly creative work linking CAP1 with resistance. It's a very interesting work that we hope will lead to some novel therapeutics. In your question about the low-dose colchicine trials, it's actually quite interesting how safe the drug was. There were some gastrointestinal difficulties, which is common when you initiate low-dose colchicine. In the COLCOT trial, there was a small increased risk of pneumonia, but it was very small. There was no increased risk of infection at all in the low-dose colchicine LODOCO 2 trial. There was no neutropenia. There was no increased risk of cancer. Low-dose colchicine has been used for quite a long time in tens of thousands of patients who have familial Mediterranean fever. That's not something we commonly see in the United States, but in the Middle East, many thousands of patients take colchicine on a regular basis for this. So I think the drug's actually very, very safe.
Yes, I have a question to Dr. Ritke as well. You showed us the figure comparing the relative risk among the several studies. When you focus on the COLCOT 2 and LODOCO 2 and COLCOT trial, COLCOT trial included the recent MI population, and LODOCO 2 included the stable CAD patient. However, the effect of the low-dose colchicine is better in LODOCO 2, including stable chronic CAD patients. Well, usually when we think about the higher risk patients, the better effect when we usually think it. But why the effect of colchicine is different even in the higher the population? Second question is that the low-dose colchicine effect in stable CAD patients is abundant, right? It's a form. However, in case of the acute coronary ischemia, the effect of colchicine is controversial. It's an issue of the lack of power, or there's another hidden mechanism that we don't know yet. Could you explain us? Yeah.
So they're both very important questions. So to me, the COLCOT trial is also a trial of chronic stable atherosclerosis. Yes, they're within 1 month of a recent myocardial infarction, but most of them are 15 days out, which, is pretty much stable disease into the phase. I think the relative risk reduction observed in COLCOT, which you correctly point out is 23%, as compared to LODOCO's 2 of 31. The 95% confidence intervals overlap. So to me, they're relatively similar. But I agree with you. In the setting of acute coronary ischemia, we have no idea. No idea. if these drugs work. There's some very small study, the COP study, other studies that have been neutral so far. There are some larger ongoing studies, but I think the biology is quite different. I think in acute ischemia, we've learned that it's thrombosis, it's fibrinolysis, it's reoxygenation of the tissue. Yes, there's a profound inflammatory response very early, but we don't yet have evidence about inhibiting that response chronically. Now, I did mention the Artemis trial with interleukin-6 inhibition. It will start the drug at the time of acute coronary ischemia, but we're going to treat for 12 months because just like you, I think it's a long-term inhibition of the inflammation that will drive the benefit for us, but we'll see.
I have a question, very practical questions. That we have a lot of the chronic stable inflammatory patients such as the rheumatoid arthritis, chronic inflammatory intestinal disease. What do you think, who is the best candidate for the calcium low dose therapy, and what is the optimal duration of the calcium for the CV preventions?
So we are giving low-dose colchicine to patients who have residual inflammatory risk and have chronic atherosclerosis. So patients who are chronic stable atherosclerosis in whom we've measured both LDL and CRP, and the CRP remains elevated. This is the patient group that we're focusing on. I'm happy that you mentioned patients with rheumatoid arthritis, inflammatory bowel disease, Crohn's disease, psoriasis, Addison's. It turns out that all autoinflammatory disorders have accelerated atherosclerosis. So it seems that whatever this signal of inflammation is, the vascular endothelium is seeing it as an adverse issue. And so probably we need to treat these patients on a very long-term basis. So the colchicine trials have treatment up to 3 or 4 years. I'm going to guess it's very similar to a statin. We probably will be treating these patients for very long periods of time. And it'd be hard to imagine why you'd stop the anti-inflammatory therapy unless there's adverse effects.
Dr. Didka, I'm Kyuk. So I was impressed by your lecture. So my question is, when I see my cardiovascular patient in the outpatient clinic, I realized the focus a little bit changed from atherosclerosis to vascular calcification. So especially in the super aged society, and I think the interleukin-6 inhibition or the colchicine might reduce chronic calcification or any other calcification of the vasculature. So do you have any idea in this area?
Well, there's a great deal of experimental work going on directly addressing your very important question. What we know is that we're getting fewer atherosclerotic events. That's what the data tell us. Remember, though, it took us a long time to learn that statin therapy, if anything, increases calcification. So I think with the anti-inflammatory drugs, we still don't have a very clear sense on this. I know you're aware a lot of very elegant imaging work with CCTA, particularly in Korea. It's a huge amount of CCTA work going on. And it's been very influential understanding what kinds of drugs can alter plaque, whether or not changing calcium can help us. I think from a pragmatic clinical situation, we have to start measuring inflammation just as often as we measure LDL cholesterol and we measure blood pressure. I've said this before that when we're in clinic, I can't imagine treating LDL cholesterol without knowing the LDL level. I can't imagine treating blood pressure without knowing the blood pressure. But many physicians are thinking they're treating inflammation without actually measuring the high sensitivity CRP. We have to get past that, and our guidelines have to get past that. We have to recognize how important this inflammatory process is as we move forward with therapy. Because again, I want to come back to Professor Kim. He was making a very good argument that combined lipid lowering with aggressive anti-inflammatory therapy is likely to be the future of atherosclerotic treatment. And I fully agree with that. I think that that's where we're heading, and how we get there, whether it's with a a CAP1 resistant molecule, or we get there through some other mechanism. That's what's fascinating to me.
Regarding the association of coronary calcification and inflammation, statin may reduce the inflammation, and actually it may alleviate calcification. We published a paper in PLOS Biology about 10 years ago regarding the mechanism of vascular calcification. The mechanism is shown like this. The bone marrow-derived mesenchymal stem cells are circulating. They home to inflamed plaque, and then they may change the fate into adipocyte or osteoblast. Thus, in the presence of cytokines, they may tend to differentiate toward osteoblast, leading to calcification of vessels. In this point, when we activate PIPA gamma agonist is a kind of regulator of transdifferentiation of mesenchymal stem cells toward adipocyte or osteoblast. It can block differentiation toward osteoblast, alleviating vascular calcification. Thus, in this context, I think the initial trigger of homing of osteoblastogenic mesenchymal cells to plaque is inflammation. Thus, when we captured inflammation early phase of plaque, we can prevent coronary calcification.
I'd like to ask you, Dr. Kim. So you showed very strong association between CABAN and PCSK9 and inflammation. And you performed a lot of animal experiment in animals of having metabolic disorder. So they showed increased level of PCSK9. So my question is, in patients with metabolic syndrome, they may show increased level of PCSK9. So
in the review process and the revision process of Nature Communication, they request us to check the human sample. Thus, we prepare the human circulating monocytes from healthy control without statin treatment from patients with CAD undergoing coronary stenting or coronary angiography treated with statin. To our surprise, the level of PC9 in monocytes or circulating blood is lower in a healthy population and higher in the patients because of statin treatment. The statin induced not only transcription of LDL receptor, but also PC9. The statin treatment significantly increased PC9 level in circulating blood as well as monocytes. It's very interesting. Thus, we may need another anti-inflammatory agent to just compensate the side effect of statin therapy to increase PC9.
Okay, Dr. Kim, you said this is CABAN play important role in inflammation. So, however, as far as I know, inclisiran siRNA also failed to decrease hsCRP level, although PCSK9 level down by more than 80%. So, how can you explain?
I guess inclisiran may be better than avalokumab and allokumab. As I mentioned before, the scheme. Inclisiran significantly reduced amount of PC9. Thus, that may reduce cholesterol level as well as inflammation. Thus, in comparison with avalokumab, I think inclisiran may have a double action. Of course, there may be some weakness to suppress the anti-inflammatory molecule by inclisiran, but I guess that may be better than avalokumab or allokumab. We need more extensive data. And theoretically, when we effectively blocked PC9 and CAP binding, we can erase the inflammatory signal. But I guess inclisiran may reduce PC9 amount, not totally, just 80% decrease. Then there is still remaining signal between the remaining 20% PC9 and CAP, that may trigger some maintenance of inflammatory signal. But actually, inclisiran may be a better strategy than a blocking antibody like abloquimab.
Thank you for all the questions and discussions. And then the session time is over, and the next session is waiting. So I enjoyed the lectures and discussions. So especially thank you for joining this symposium, Dr. Lidker. And we are all looking forward to seeing you next September in Seoul. And I'm going to close this session. Thank you.
Thank you. I look forward to seeing you.